Hi, everybody. This is Julie Salvador. Welcome. I'm going to introduce Dr. Madden to everyone. Dr. Erin Madden is a faculty member in the Department of Family Medicine and Public Health Sciences at Wayne State University School of Medicine in Detroit. Her research explores social factors affecting healthcare for people who use drugs, with a primary focus on stigma towards substance use. Dr. Madden's work weaves together insights from sociology and public health in an effort to understand how discrimination and prejudice operate among health professionals toward people who use drugs. Her most recent work seeks to develop stigma reduction interventions for primary care providers, mental health professionals, and clinic office staff. Dr. Madden received her doctorate in medical sociology from the University of Wisconsin-Madison in 2014, and her Master of Public Health degree from the University of New Mexico School of Medicine. Thanks, Dr. Madden, please take it away.
Thanks so much for having me. So as you've heard, I have a little bit of a connection to New Mexico. I actually lived in New Mexico from 2013 until just 2020. I was a faculty member in sociology at CNM for 2.5 years. I got my MPH at UNM, and then worked for a couple years with Miriam Kamarami at Project Echo on substance use research as well. So I miss it a lot. The weather is way better there than Detroit. So I think about visiting frequently. So I hope to do so soon. Thanks for having me again. So I have no conflicts of interest to report. What I'll be talking about today is the relationship between language and stigma. First, I'm a stigma researcher. This is what I think about and do research about pretty much all day. I want to talk about some of the terminology updates that are being suggested, and then make a case for why language is important for reducing stigma, and then talk about putting updated terminology into practice. So what is the relationship between language and stigma? Well, first, what is stigma? So I think a lot of people know what stigma is, but there's an overemphasis on one piece of stigma, and that's to the detriment of really all of us for actually addressing what stigma truly is. So stigma is when a person or a group experiences prejudice or discrimination in a society because of a particular characteristic. So prejudice is like the attitudes piece of stigma, and people tend to focus so much on the attitudinal components of stigma and really don't pay enough attention to the discrimination piece, which is the negative actions part of stigma. And I would argue that we need to pay attention to both of those, and that language is an example of the discrimination piece. And that's why we need more attention to things like the language we use related to substance use. So stigma can be intentional or unintentional. The outcome is really the same. In the same way, we've heard a lot in the last decade about implicit bias or unconscious racism, right? That's another way in which stigma can operate, because stigma actually is the umbrella under which things like racism and classism also are subsets. We also need to pay attention to not just the ways in which we knowingly maybe cause harm or have judgmental attitudes, but also the ways in which we unintentionally and unknowingly do those things. So my research is focused on stigma towards people who use drugs in particular, and examples of the stigma. We could spend hours on this. So this is one of the, a big booming area of research, stigma towards people who use drugs. The sort of rate of publication in this area has sort of risen exponentially in the past 5 to 7 years. So what a lot of studies are doing is documenting sort of what stigma looks like. So stigma can look like being denied care in emergency departments and primary care or pharmacies. It can be language, things like being called a junkie or an addict. And also, the criminalization of substance use is an example of stigma. So what that tells us is that stigma operates on multiple levels, right? It can operate on the interpersonal level in terms of the language that we use with each other. It can also operate at the organizational level in terms of pharmacies and emergency departments, right? Denying people care who they don't think are legitimate, right? Patients. And it can also operate at what's called the structural level, which is the level at which policies and broad social processes are happening. And so the criminalization of drug use is an example of structural stigma. We also can think about stigma on the individual level, which is something called self-stigma or internalized stigma. And that's where people who are members of a stigmatized group start to sort of believe the negative judgments of society towards them. So why should we care about stigma? Sociologists argue that stigma is something called a fundamental cause of health inequities. So fundamental cause is a theory in sociology. It's very similar to the social determinants idea. Basically, this is a theory that says there are fundamental causes like racism, like poverty, like experiencing stigma that contribute to worse health outcomes and do so through multiple different diverse mechanisms or pathways. So stigma, we argue, is an example of a fundamental cause of health inequities. And people who are subject to stigma have worse health outcomes than individuals who are not subject to stigma for that reason. So people who use drugs are a part of this. So we can imagine this, and I just laid out some of the pathways through which stigma operates as a fundamental cause for people who use drugs. So one clear example is criminalization, right? So people who have a conviction for a drug offense, even an arrest without a conviction can still cause problems in a person's life. It can lead to housing discrimination, employment discrimination, which we know then can lead to homelessness, can lead to unemployment. And then that leads, higher levels of substance use. We know unemployment leads to poverty, which leads to worse physical health, right? Other mechanisms are things like stigma towards substance use being connected to social isolation. So there's been a long tradition in our society of this idea of tough love for people who use drugs, that we need to cut them off, and anything but cutting them off is enabling, and they need to hit quote unquote rock bottom, right? So this idea that is very prominent in media that depicts people who use drugs, daytime shows like Dr. Phil advocate for this, but what it leads to is the social isolation of people who use drugs. We know then that leads to lack of social support, which then of course we know also is associated with worse mental health. Also, poor healthcare quality. Stigma towards people who use drugs means they experience things like getting kicked out of pharmacies when they're going to get a buprenorphine prescription. Or pharmacies will say, hey, we don't have your prescription. You got to wait 3 to 5 days. And a lot of people who use drugs and some of the clinicians who work with them think that that's a pharmacy trying to deter the patient from using that particular pharmacy because they don't want individuals who look like this person or who are getting this drug to be a customer at their site. Well, that of course is poor healthcare quality that can lead to limited access to treatment. And it's not surprising that if you're delayed 3 to 5 days for a medication, that this would then lead to problems with treatment adherence. So these, are multiple pathways that I'm describing by which stigma comes to bear on people's health outcomes. So this is why we should care about stigma and addressing stigma in as many ways as possible to try and undermine and eradicate as much as possible this fundamental cause of poor health outcomes among people who use drugs. So the effects of stigma are documented, and there's a lot of research in this area. So we know that stigma can worsen people's social conditions and resources. People who use drugs experience, like I've said, housing, employment, and educational issues. So once you have a drug conviction, you become ineligible for certain types of federal funding for education. Also, clearly, stigma towards people who use drugs can worsen healthcare quality, can do things like create barriers to medications for opioid use disorders. And this is where, my research tends to focus. So it can lead to patients doing things like delaying medication initiation, so not starting treatment, or prematurely stopping their medication treatment because they feel so stigmatized, they feel so devalued. It also can contribute to discharges against medical advice. There's a lot of research out of Canada showing that. And then unsurprisingly, it leads to things like avoiding prenatal care. If you're a person who uses drugs who is pregnant, chances are you are afraid of your provider reporting you to the child welfare system and losing custody of your child. Maybe you've already lost custody of children, so you're avoiding physicians for that reason because you don't want to be reported again, right? None of this is surprising, but this is the system we have set up, unfortunately, for people who use drugs. In some states, physicians are mandated to report that a person is using drugs in ways that are potentially harmful, and that will open up the child welfare case against that individual. There's also a lot of research that says that actually stigmatizing people is not a motivating factor for treatment. And in fact, it becomes a barrier for treatment, that people who are feeling stigmatized for their substance use are less likely to enter treatment than individuals who feel less stigmatized. There's also research on a phenomenon called treatment carryover, by which people avoid treatment for a stigmatized condition because they're worried about going to get treatment will reveal that they have the issue. So avoiding mental health care because they're worried if I walk into this clinic, people will know I'm seeking mental health services. The same thing has been documented with people who use drugs, avoiding treatment for that reason. And of course, none of this is, it's not surprising that this then leads to worse health outcomes and behavioral outcomes. So we see that people who report higher levels of stigma engage in higher levels and more harmful kinds or risky kinds of substance use. They have worse mental health symptoms, and thinking about co-occurring conditions, they have worse HIV treatment adherence and then worse HIV symptom severity. So stigma is not just hurt feelings. Stigma absolutely affects services, affects experiences, and affects health through all these pathways that we're describing. So one of the arguments for how can we reduce stigma towards this patient population, one argument has been, well, one thing that we can do is at least change the language that we use to refer to people. Is this the be all end all of stigma interventions? Of course not, right? But it is an essential component of stigma reduction, I would argue, and I'll show you the evidence for that in a minute. But I first want to show that part of the sort of call for the language shift has been inspired by other past language shifts that have been successful in sort of changing public perception and clinician perceptions of the patient population. So Sarah Wakeman, who is a researcher who studies substance use and has been doing a lot in the area of stigma, and she's a physician, she has argued that, you know, we've made these changes for other stigmatized conditions, and so we should do the same thing for substance use. And so she talks about three sort of comparable stigmatized groups and says, here's how we change the language, so we should do the same thing for substance use. So she starts by saying, you know, let's think about the example of HIV. So HIV, when it first emerged, was called the super pejorative and homophobic label of gay plague. So not only is it homophobic, it's also epidemiologically inaccurate. People who do not identify as gay, of course, might be living with HIV. But also referring to people with HIV as HIV victims or HIV sufferers. So activist patients said, we don't like that either. We're glad you stopped calling it something homophobic, but we're not, you know, we don't want to feel disempowered by the labels that you give us. So people living with HIV said, actually, please say that we're people living with HIV. Don't call us HIV victims. Don't call us HIV sufferers, right? Another sort of shift in language that you all probably know a lot about is, right, the language around mental disorders. So moving away from language like crazy, insane, or psycho, which are clearly pejorative, but also very vague, and they're not person-centered. And there's some evidence that these labels tend to stoke fear and increase expectations of violence from a particular patient. So instead saying person living with, if we have a sense their diagnosis, write their diagnosis, or a person living with a mental disorder, or a person living with a mental illness. The third change is moving away from language like committed suicide. So removing the word committed from our discussions of suicide, because committed is a word we use to talk about actions that are sins or crimes. If we are working as professionals in healthcare or some other behavioral health context, we are not necessarily in the business of sin or criminal justice. We should be talking about it like we talk about other causes of mortality. So people died by suicide. If we want to acknowledge the emotional component of that death, we could say maybe lost to suicide, but again, avoiding that committed term. So what Sarah Wakeman argues is that in these cases, there's been a move towards language that is two things. It is medically accurate and it's person-centered. So this is the sort of part of the argument behind the change in language, that we've seen it happen in the past, and these have resulted in better care for these populations. But I will make one sort of asterisk, one note about her argument, which is that medically accurate labels are very important. But there has been a little bit too much of an emphasis on the medicalization of substance use as the answer for stigma. So medicalization is a sociological term for the phenomenon by which things become sort of under the purview of medicine, right? So moving from something that's maybe just like a habit to something that now is a condition or a diagnosis. So that process can provide really important resources to patients. So once we medicalize substance use, well, now insurance can be billed for treatment, right? There's benefits to medicalization. However, medicalizing something, using medical terminology for something, does not free it from stigma. I wish it were that simple, but sociologists have done a lot of work on medicalization and just do not see the evidence that medicalizing something takes a stigma away. It can still be useful. It can still maybe provide benefits like insurance coverage, improvement in the science of the condition, but it alone cannot destigmatize. So it doesn't mean we should not medicalize things. So there is a debate about the medicalization of substance use disorders, but we won't get into all that today unless you want to. But medicalization alone does not reduce stigma, but it can be a component of how we address stigma, but it alone is not enough. Okay. So what are the terminology updates? Well, clearly like person-centeredness and medical accuracy could be valuable, but there's more that's suggested aside from referring to people who use drugs as people first and foremost. There's actually been a lot of discussion about what is respectful language? What is language is unintentionally stigmatizing that we need to address? So I've spent the last few years trying to document all the suggestions that I've been given. Some of these came to me on Twitter. Some of these were people correcting my language. So this is really a lifelong process. Even as someone who studies stigma, I find myself sometimes learning ways in which I unintentionally stigmatize people who use drugs. So this is not an indictment of any of your language, but a sort of group thought process about what we can do better. So some of these will not be surprising and some of them might be to you all. So when we're talking about the use of drugs, old terminology use the idea of substance abuse, right? And I still hear this all the time. I'm in a family medicine department. Some of the clinicians in my department use this term, and I just try to model using a different term, which is substance use. The argument here is that the word abuse is a word for the mistreatment of living things. So animals, the elderly, children, right? And that no one is like a drug then or a substance then cannot be abused because it's not a living thing. And we have very negative societal perceptions of abuse and abusers, right? And that it's not fair to use that same term for people who use drugs. So moving away from that word abuse and instead using a more neutral term like use. Another sort of set of old terminology is like the clean dirty dichotomy, especially when we're talking about urine drug screens, but also syringes and needles, and also not referring to drug screens as a failed drug screen if the person indicates drug use in their urine drug screen. So instead of we're talking about needles and syringes, saying used or unused. So this was a correction that was made to me about my language from a friend of mine who helped to start the first syringe distribution program in the state of Utah. She heard me say clean and dirty needles in a harm reduction training. And she raised her hand and said, nope, we're trying to not use that language. You could try to not use that language too. That would be great. And I sort of said, oh, of course, can you say more? And she said, we often know that it's not okay to refer to people as clean and dirty. That's not revolutionary. But sometimes even referring to the things that have touched someone who has been called dirty many times in their past can still sort of evoke that negative emotion, make them disengage, make them feel bad about themselves. She said, so we try to say, maybe we'll say sterile or unsterile, but usually we try to say used or unused for needles. So that was a learning experience for me in 2020, maybe 2019. So again, continually learning. And then urine drug screen, substance use or substance free. And then talking about return to use. So instead of saying relapse or recidivism, saying return to use or recurrence. So recurrence being a more neutral term, more used in other chronic conditions. Though that is not to say that all substance use disorders are chronic. There's debate on that. Some are, some people fully recover and it's not a chronic condition for them. And then especially moving away from that word recidivism. So recidivism is a term from the criminal justice field that relates to a return to, or like a re-offense against a law. And if we're saying that criminalization drives stigma, we should not be using criminal justice language in our conversation. So moving away from that criminal justice perspective on substance use and instead saying return to use or recurrence. The last two on this page were ones I actually felt I needed help with and went to Twitter and asked people, what would you use instead? So they were doctor shopping and drug seeking behavior. People suggested seeking relief. So that was coming from the idea that if someone is going to multiple providers and trying to get maybe an opioid prescription, or is perceived as trying to get an opioid prescription, that maybe all they're trying to do is seeking relief from chronic pain, from trauma, right? But they're seeking relief from something. Another person said, well, isn't this just getting a second opinion, which we encourage patients to do in all sorts of contexts? Why not this one? Which I thought was a really interesting response as well. The one I think is maybe most useful is, instead of using these sort of colloquialisms and sort of negative interpretations of a patient's behavior, using more descriptive and neutral language in documentation. So things like patient has seen multiple providers, patient has chronic unmanaged pain. So if you think about it, if you're looking at charting from another provider, you're going to have a certain disposition potentially towards a patient if you read doctor shopping or drug seeking behavior, versus if you read a chart that says something about patients seeking multiple providers. So this is also giving your patient the chance to experience a provider who is not starting from a disposition of mistrust. So thinking down the line, who's going to see these notes, making sure the language is more neutral to give that patient a chance to build a good relationship with that provider, instead of the provider maybe from the get-go having some distrust. Okay, when talking about diagnoses, the term addiction is used in the past, it's still used today, but I put an asterisk on it because I've been told that some people do consider the word addiction to also be stigmatizing because it's vague. So that was a critique of some of the earlier terminology has been changed. Well, addiction is also a vague term, maybe an overused term. So people use the term addict or addiction for things that do not meet the criteria of addiction, that may be more like our very periodic binge drinking or binge substance use, but don't, really satisfy the criteria for substance use disorder. But I think that one's still really debated about whether it's stigmatizing or not. But of course, most of you know, right, we no longer talk about drug dependence or drug abuse, that those sort of old categories of substance use were subsumed into the new substance use disorder criteria. And that we have, within that different types of substance use, but really avoiding, things like drug habit or drug problem that frame someone's drug use, even if they are risky types of drug use or things that are causing problems in their lives, but moving away from that really negative language and having more clinically neutral language. When we're talking about individuals, of course, not referring to people as addicts, alcoholics, abusers, or users, but using that person first language we've seen being successful with other types of conditions like HIV. And finally, babies born to parents who use drugs, so not referring to that baby as an addicted baby. Babies cannot meet the clinical criteria for addiction. So instead, saying things like a newborn exposed to substances, baby with signs of withdrawal from prenatal drug exposure, or diagnoses like a baby with neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. And then the last set of suggestions is when we're talking about treatment, there's one that's a very recent change that I even have published a paper that used the old term in 2019, so pretty recent. Moving away from having MAT, mean medication assisted treatment. The issue is with that word assisted. The thought is that is implying that medication is assisting a more primary or central or legitimate intervention, something like a type of talk therapy. But medication in and of itself is treatment. Medication alone without any sort of other behavioral intervention has been shown to improve outcomes. So should be framed as a treatment in and of itself. So the suggestion has been, if you want to use that MAT acronym, to have it mean medications for addiction treatment instead of medication assisted treatment. And then also not using terms like replacement therapy or opioid substitution therapy, because sort of the equating of illicit opioids to methadone or illicit opioids to buprenorphine often is used as an argument to undermine those interventions. So trying to move away from that language and saying things like opioid agonist therapy or pharmacotherapy. And if we're talking about, buprenorphine or methadone or naltrexone in particular, we can say medications for opioid use disorder, MOUD. And then talking about people in treatment or recovery. So again, staying away from that clean, dirty imagery. So not referring to people as being clean, but instead being in remission or recovery or abstinent from drugs. I have asterisks. I can't say that word in plural, there, because the definition of recovery and abstinent is actually variable. To some people, recovery is anyone sort of moving towards a positive change in their life. They might still be using drugs, but they're making a positive change. To other people, recovery means I have not used drugs for X number of time, X number of years. And same with abstinent. Some people think abstinent means I don't use any drugs at all, no alcohol, no methamphetamines, right? And to other people, maybe it means I used to have a methamphetamine use disorder, but now I do not use methamphetamines, but I still drink alcohol, and I'm abstinent because I'm abstinent from the drug that I had a condition related to. I was actually watching the show on HBO, Hacks, maybe you've seen it. And there was one actress who said, she's in recovery, and she said to the other actress, I want to go to the bar. And the other actress said, well, I thought you were in recovery from cocaine. She said, yeah, from cocaine, I can still drink, and it made me think about this idea that abstinence or being in recovery has multiple meanings depending on who you're talking to. Okay, so because all of these sort of language shifts are going on, there has been growing calls to change the names of organizations and agencies and research journals. A lot of people and groups, right, that have been addressing substance use have some of these stigmatizing terms in their names. It's not easy to change a name, but I would argue, and I will argue in the next set of slides, that we should, because these words have real impacts. So actually, there are name changes in the works for our federal organizations. So these are expected in 2023. So NIDA, the National Institute on Drug Abuse, will be changing its name to the National Institute on Drugs and Addiction. NIAAA will change their name from the National Institute on Alcohol Abuse and Alcoholism to the National Institute on Alcohol Effects and Alcohol-Related Disorders. I don't know if the R is going to make it into their acronym, which is why the question mark is there. It's a very long acronym otherwise. So SAMHSA will be changing its name from the Substance Abuse and Mental Health Services Administration to the Substance Use and Mental Health Services Administration. I think at UNM, right, CASA recently changed its name as well. So we're seeing this happening with lots of organizations, which is great, and especially for NIDA, because NIDA for at least a year, maybe 2 years, has had guidance on respectful, non-stigmatizing language that its own name broke the rules of, right? So it said, don't use the word abuse, but then NIDA's own name says abuse. So it's good that they're moving in that direction to try and address stigmatizing language. So why should we make all these efforts? So especially some people have asked, why should I do this when patients use these terms? Yes, it is extremely common to hear patients refer to themselves as addicts or things that are even more pejorative than that. And I would argue people who use drugs can refer to themselves however they want, because oftentimes this is an effort to reclaim a label that's been used against them in a negative way. This is sort of a similar to what we've seen with the term queer, right? That LGBT people have said, I'm reclaiming that one. That's me. I wear that, that label with pride. But that's one of the rare cases, I would say, of a successful reclamation of a slur or a stigmatizing term, that in general, stigmatizing terms have not been successfully made into non-stigmatizing language. So I would argue clinicians and researchers and other professionals really should stick to the updated terminology. And that's because I really think it patterns the way, based on research, that this is patterning the way people see patients and interact with patients. So a 2010 study shows some evidence of that. So this study looked at 500 plus mental health professionals. They were randomized into different vignette groups and found that a vignette that referred to someone as a substance abuser elicited greater agreement with punitive interventions like jail than when the same vignette was given, but just described the individual as a person with a substance use disorder. A 2019 study of implicit bias showed that among 63 healthcare professionals that there were greater negative associations with the term substance abuser than a person with a substance use disorder. So if we have negative associations with these terms, if they elicit different sort of responses and we think is the right course of action or treatment for these individuals, then we really need to think about the terms we're using. They're not benign. They pattern the way we act and perceive individuals. And I do think language is contributing to a lot of the attitudinal issues we see among professionals in all sorts of areas of healthcare towards individuals who use drugs. So we see from a European study of 800 plus professionals that attitudes towards people who use drugs are much worse than attitudes towards patients with other types of diagnoses. So this is especially true in primary care and general psychiatry. So this study found the lowest positive attitudes, so the worst attitudes towards people with alcohol use disorders and illicit drug use disorders in primary care and general psychiatry compared to patients with depression or diabetes. And the attitudes were much flatter and more positive among people who work in specialty addiction. Does this hold in the United States? It does. So studies have sort of suggested that the same patterns really exist in the United States. So a study of 600 plus primary care physicians that was very recent found pretty negative attitudes among large proportions of people who work in primary care. So only about 20% had an interest as a primary physicians in the US, primary care, had an interest in treating patients with an opioid use disorder. Only about 12% had an interest in obtaining a waiver to prescribe buprenorphine in the future. Only 67% thought that opioid use disorder treatment with medication is more effective than without. So that is over 30% of primary care physicians do not believe that the gold standard treatment for opioid use disorder works. That's concerning. And if we're looking at it by which medications they're being asked about, the attitudes towards methadone effectiveness are very, very low. Only 62% are saying that this is effective for treatment of OUD. Higher percentage, 77.5%, think buprenorphine is effective. But think about who's left over, right? We have large proportions of primary care physicians who do not believe in the medications that work, and they're not that interested in treating patients who have substance use disorders. And then looking at psychiatrists in the US, this is a smaller study of 84 psychiatrists that found that community psychiatrists have the lowest positive attitudes, so the worst attitudes towards patients with polysubstance dependence, and the highest attitudes towards those with schizophrenia. And then addiction psychiatrists are much more willing to have sort of positive attitudes towards individuals with polysubstance dependence. But what I think is interesting here is that the dual diagnosis patients are pretty low for both. So if we're looking at community psychiatrists, they're most willing to work with someone with schizophrenia. They have the highest sort of regard for them. But then the dual diagnosis patient who has schizophrenia and polysubstance dependence is lower than that. And then for the addiction psychiatrists, they're most willing to work with someone with depression and polysubstance dependence, but the dual diagnosis patients is below that. So there's also intersecting types of stigma that matter here, that we're seeing attitudes towards sort of some types of patients with substance use are even more negative than the general attitude towards patients with substance use disorders. And it's not just that language affects potentially people who work in healthcare services. This also affects people who use drugs. So there was a systematic review and meta-analysis that looked at across 134 studies, how does sort of feeling discrimination affect people? And this is not just specific to substance use disorder. This was inclusive of people with all sorts of types of stigma, so people on the receiving end of substance use stigma, but also other types of stigma. What it found was that consistently across studies, that being on the receiving end of discrimination makes one more likely to experience stress, more likely to report having unhealthy behaviors, and then to have worse physical and mental health outcomes. So this really can impact patients and how they see themselves and how they take care of themselves and then their health outcomes. So how do we put terminology, these terminology updates I've suggested, into practice? Well, first of all, why should we do this? I would argue we should do this because the language we use reflects our conscious and unconscious biases, and it affects our actions and interactions with others. I would say there's not great research that has directly measured how does using respectful language versus stigmatizing language affect things like the therapeutic alliance. We're not there with stigma research yet. I hope that research comes out soon. But the research that I went over from 2010 and 2019 suggests that it does pattern the way physicians and other types of healthcare professionals sort of see patients and think a patient should be dealt with, right? Or should be cared for. Is that prison or is that treatment, right? So I would argue that we have some evidence that is decent, that it does pattern our interactions and our actions. We need more research in this area, but I think, there's a pretty clear indication of what the results would likely be from those studies. And also, I think we need to look back at that fundamental cause idea. If we know stigma has all these downstream effects on people's health outcomes who use drugs, and stigmatizing language is a piece of stigma, then we really need to think about addressing it, because this will have downstream effects. It's not just an issue of semantics, as I've mentioned before. So stigma has all these effects on things like people's access to treatment and healthcare, their adherence to treatments. I also would argue it affects how the larger community sees people who use drugs. So oftentimes people in our communities look to individuals who do research related to mental health and substance use, who provide care to those populations. They look to us for some level of guidance and authority and expertise on these individuals. So the way we talk about them has ripple effects in the broader community. So it can affect indirectly things like whether an individual is willing to employ someone who had a substance use disorder, whether someone's willing to provide housing to that individual. And also people's support of public funding for services for people who use drugs. If we're all saying negative, pejorative things about individuals who use drugs, are the people around us going to vote for individuals who are willing to fund, services for these people? Or are they going to say, nope, those people aren't worth, right, the resources in our society? There's more deserving groups of people. So I would argue everything we do and say as people who work in this field has ripple effects, and we need to be aware of them. So that kind of wraps up the research portion. And I know I'm supposed to talk for a little bit longer, but I would love it if there could also be a little bit of discussion, because I think also I have a lot of questions about what it looks like to implement language changes in clinical services. So I'm a researcher. I don't spend my day to day in a clinical environment. So I'm curious about what you all think in terms of how could you implement substance use changes in your work, substance use language changes in your work, what benefits could emerge from those changes, but also what challenges could arise from those changes. And I'll just tell you a little bit about myself in terms of me trying to do this. So I work with a lot of family physicians. I try to model appropriate language. I'm always saying substance use, people who use drugs. I very rarely get that language mirrored back to me from clinicians. They still say substance abuse, addicts, right? That stuff still happens with my colleagues. And I'm not exactly sure how to implement the language changes with that. Maybe I need to give this talk in my own department. I'm not sure. But I would love to hear some ideas and some thoughts. And that's pretty much it for me. I thank you so much for listening to me talk. And I'd be happy to say more about any of this or about stigma research in the substance use field.
Thank you very much, Dr. Madden. Yeah, so let's just open it up. I know there was a question in the chat that I saw earlier that maybe you could address. It's from Dr. Patty Fernandez. I'm sorry, I'm not looking at it right now, but it was the word relapse prevention. What would be an alternate terminology?
So you could do return to use prevention, which is a kind of wordy, or recurrence prevention. I would say not everyone agrees that relapse is stigmatizing. But I don't know, I think we don't say relapse for a lot of other less stigmatized conditions. So I could see the argument there. So I think that one, is a relapse prevention or a super stigmatizing phrase? I'm not sure. But if you want to be really careful, I would say preventing return to use maybe, or recurrence prevention. That's a good question. Oh, someone said instead of substance free for UDM, we use lab language, positive, negative, expected, unexpected. Those are fine too. Yeah. Some people are like, oh, but you can't say positive and negative, but the positive is for drug use. So it's not necessarily like stigmatized. To me, I don't know why someone wouldn't be okay with positive, negative. So I think that's acceptable too. So.
I have a question about the patient use of language that's, reclaiming like the word addict or whatever. Oftentimes we are sort of trained or encouraged to use language that the patients themselves use. So if they refer to bipolar disorder as manic depressive illness, to be sort of, to use patient centered language and the language that they themselves use. I'm just curious if you have thoughts about that.
That's a great question. I mean, one of the approaches could be to talk to them about the language shift that you're thinking about doing and seeing how they feel about it, and like providing the thought process behind it, right? And if they're like, no, I don't want to hear that, I mean, that's fine. I mean, because the goal is really to be patient-centered and have them feel accepted. So, I mean, to me, if someone really was insistent on it, I guess I would let them say, I don't know. I would have trouble with it because I really don't love saying that word, like saying addict. It's a really good question. I mean, what do you think too? What would you do?
I mean, I similarly don't like the word addict. I think I would probably, use the language that we are encouraged to use here in this talk, and use alternative language, and, just sort of, quote, allow them to use whatever language they're going to use. So they can describe their illness how they, much like, I would document using the similar example of bipolar disorder versus manic depressive illness. I might put in quotes somewhere in my note that they said that their manic depressive illness is, well controlled, but later on in my note, I would refer to it as as bipolar disorder. I think I would, continue to use the appropriate language, but, allow them to talk about themselves and their experience, however they sort of feel is appropriate.
Yeah, that makes sense. And sometimes I also think people use the words that were used around them, and they're not always aware of alternatives. I mean, a lot of times they are, but sometimes they're not. And so offering those alternative ways of seeing them could be also helpful. So
thank you.
Thank you.
And I see a hand raised, and the name that I can see on the screen is N. Kelly at FCD Recovery. Did you want to unmute yourself? And
yes, good afternoon. Thank you and for sharing the changes. The atmosphere will probably change as well. And one of my biggest concern, as always, was the Alcoholics Anonymous, the ritual, the saying, and identifying individuals identifying as I'm an alcoholic, and alcohol all the way down. So during my traditional breakout in the past, I would say that you are a Native American first, and your alcohol or substance use disorder is a condition or an illness. So I've been using that a lot, and people seem to appreciate that. So what are we going to do with the changes? Maybe and start working who has jurisdiction over those words with that one too. Thank you.
Yeah, that's a great point. And it sounds like you're already doing really important like language work with the individuals you're working with. I mean, yeah, Alcoholics Anonymous and Narcotics Anonymous embrace the terms. And I'm saying don't, right? I'm saying don't use those. But again, that's like a peer support group. So these are individuals who are going through substance use disorders or recovering from substance use disorders. So again, though, I think they're allowed to refer to themselves however they want. However, if someone is saying that, makes me feel bad, or I don't like that label, which is what some people from those organizations feel, not everyone agrees with that practice, then, it's helpful to model a different approach too. So I wouldn't tell people in NA or AA to do anything different because I'm not a member of those organizations. And I do believe in like their democratic right to determine what those look like, what they do and what they want to do, that's up to them. But I think, in a professional environment, not a peer support environment, that the language should follow, best professional practices. So, but I think it's great what you're doing. That's wonderful. I think Melissa Walker's hand was up next.
Hi, my name is actually Dana Demas Curtis. I'm borrowing the warmth of my coworker's office. I am wanting to check in with you guys or with you about useful and appropriate language around talking to parents, specifically moms who have used substances in pregnancy, and it may be appropriate to talk to them about their child's development and whether that may be playing a role in like that use during pregnancy, playing a role in their child's current developmental kind of trajectory.
Yeah.
How I can use words in a more effective way, if you have suggestions.
That's a really tough one because, you know, based on all my qualitative work, that is like one of the hardest areas for patients, and patients just really disengage sometimes when you attribute any sort of stuff their child is going through to, you know, prenatal substance use. And it's because that, you know, that elicits some guilt and stuff like that. I mean, I do think sometimes, you know, as someone who's the parent of a 9-month-old, sometimes there's an over attribution of issues or delays that a kid has to parental substance use, and people, you know, are so quick to say, you know, maybe it's related to that prenatal drug exposure, but maybe like assess whether that's the best way to frame any sort of like issues that are arising. I mean, I guess if they directly ask you, then there's really not much you do, you know, and I would just make sure to refer to it as just like drug exposure prenatally, or like it's like very neutral clinical language as much as possible. Have you tried that, and has that still resulted in some difficult interactions?
So I work in an autism clinic, and the interesting part is that I'll get questions around things like this, where the mom's like, oh my gosh, I was using X drug in pregnancy before I knew I was pregnant, and could that be like causing the problem that my child was having? So that's kind of a common way that it might come up, but I try to keep it as clinical in the speaking of language, or excuse me, of specific substance use, to try and make it not be something where I'm explaining, you know, that this could be the issue. But there have been a couple of times where someone has told me about use during pregnancy, and the parent is not really aware that some things could come up that that might be affecting. So I'm looking at autism specific things, but alcohol exposure during pregnancy might affect the child's social skills. So we might talk a little bit about that more. I don't know if that gives kind of a little bit more information about how those conversations come up.
Yeah, I mean, it's a really tough conversation because you don't want the parent to shut down because they feel guilt or blame. However, you also want to honestly answer questions about potential risk factors that, yeah, I mean, I would frame it that way, you know, like there are some risk factors, but we don't know for sure that these are causally related, that just because you did this, it means this happened. You know, so maybe like expressing some of the scientific uncertainty around that can be useful for them, because that means that, you know, it's maybe not what was the causal factor. I mean, that's a really tough interaction, and I think this would be a great area for research to try to work on, is talking to parents of parents who use drugs about their kids' development. I think we don't know best practices for that, unfortunately. So it sounds like you're already thinking about, though, making sure, trying to hedge off any guilt that might emerge, and trying not to do blame, which I think is the best practice that I would recommend. So
thanks so much.
Thank you.
I don't see any other hands up at the moment. Any other questions or comments from anybody?
Yeah, I'll jump in real quick. I just wanted to kind of go back to people self-identifying as alcoholics or addicts. And note that I've seen a number of providers express discomfort with people self-identifying that way, or this practice in 12-step programs of this self-identification, which is not required. You know, in a 12-step program, you can identify any number of ways that doesn't use that language, which can be, I have a desire to stop drinking, or I'm a member of AA, or whatever. But I noticed that some providers are uncomfortable with other people using that terminology. And it seems to be based on the provider's own stigma of that word, and not necessarily the person who is using that term about themselves, for which it can be, like you mentioned, it can be empowering, or evidence, you know, to them that, you know, they're a part of a group. And so I don't know, that's just something I have been thinking about.
I think it's a great point. And I think if people want to reclaim it and that makes them feel good, then that's legitimate, right? Like, who are we to tell them anything else? You know, I would just say, I personally would not use it because I'm not a member of that group, right? So being careful in that way. But yeah, I think Danielle, you bring up a really good point.
And I would say it's a difference between people self-identifying and being called that by their provider. Those are two different things, right? Yeah, so I would never refer to a patient as an alcoholic or an addict to them, but think it can be useful for them if they feel it is so.
Absolutely. So like our social position in the interaction matters, right? Absolutely. I think Allie Bushing, I might have mispronounced your name, sorry.
No worries. So I didn't have a question, but just wanted to say thank you for doing this training. I work in harm reduction and with people who use drugs, and hear reports pretty much every day of folks, sometimes with pretty severe medical conditions, that are hesitant to seek care in mainstream systems because of, you know, a certain provider or just an experience they had. Sometimes it only takes one, you know, bad interaction for someone to really be cautious about going back. So just really appreciate the efforts that everyone here is taking to create more inclusive and well-use drugs.
Yeah, absolutely. I mean, people that I've interviewed in my research talk about being like called an addict, but very casually. The person's not even trying to stigmatize them. They're like, oh, you're an addict. Okay. When they answer the substance use questions and they come into emergency department or primary care, and then that immediately turned the individual off and they decided to leave or not get, you know, their abscess looked at or whatever. So, you know, that's clearly going to result in worse care. We want people to feel comfortable coming to services. And if, you know, you don't know if they're the individual who's fine with that terminology or not. So it's better to err on the, you know, the other side. So.
Dr. Madden, this is Julie Salvador. I have a question. You were asking at the beginning about, like, you know, kind of what might be some strategies for, you know, implementing or changing this. What are the results of just a very simple top-down strategy of, let's say, just for example, the University of New Mexico, just the whole thing, that there's just a statement that comes out that says, hey, we've got a panel of people together. These are the preferred terms and language, you know, here's the list, and it could be, you know, really big. It doesn't have to be just substance use. What are the effects of that? One thing that I think of is that at least then there's some kind of, you know, general statement that's gone out to everybody, which makes it a little easier, I think, in context when people might say one thing or another, because I know sometimes people are very quiet. They don't want to correct somebody, a colleague in public. But we all make, you know, mistakes or use terms that maybe we shouldn't sometimes, just out of old habits. But is that a successful strategy? Just having kind of a general agreement from a large institution, you know, whatever, Presbyterian Health, this is the terminology we use for these different conditions. These are the kind of language. Is that effective or not?
Great question. We don't know. So from like an implementation science perspective, we know that leadership buy-in matters for all sorts of changes to practices, but we don't specifically know if leadership buy-in and endorsement of changes to language results in significant changes to stigma or improvement in patient care. We don't know. There's not a study that shows that yet, unfortunately. one of the things would be interesting is if UNM does adopt something like that, trying to measure, right, whether it does have any effect, because there's no study that shows that at this point, unfortunately.
All right, thank you. Yeah, I'm just thinking in terms of maybe not in those particular outcomes, but just in using the language. So, when we go into healthcare facilities now and it says, hey, your provider is supposed to wash their hands or whatever, and ask them if they have. So there's a real open kind of acknowledgement of what is the best practice, and everybody's on the same page. So when it doesn't happen, it's easier to call it out than when it's kind of unwritten and, ooh, Dr. So-and-so didn't wash their hands, but I don't want to say anything because, there isn't sort of that acknowledged thing that they've done in those other areas. So just thought I wanted to see what the results are, those kinds of strategies. Thank you.
It's a great point, and I think you're absolutely right that when there's unwritten rules guiding behavior, then that is a problem versus making them explicit. Now you have a mechanism to sort of address and measure, right, any changes or infractions, right? So there's clear benefits to the sort of institutional buy-in and rule making and policy making, but we just don't have a study that clearly measures them. But I think what you're saying all makes sense, and I agree, absolutely.
Well, thank you. I know we have a few more minutes, so if anybody has any other questions, if not, I guess we'll all comfortably sit in silence for a minute or two. And then, yeah, thanks, Lily. Thank you very much, Dr. Madden.
Thank you so much for having me.
Lily, I don't know if you want to jump in, if there's any kind of official closeout.
Hi, everyone. There's not a super official closeout, but thank you for everyone for showing up. I think this is the highest turnout that I have ever seen in our grand rounds. We got up to about 135 participants, so that is awesome for us. I put the feedback form in the chat. If you have some time afterwards to fill that out and send it back to us, we really appreciate any feedback. We use it to help structure our program for the future as well. So thank you again, everybody, for coming. I'll go ahead and end the recording and put the QR code back up for anyone who still wants to sign in for credit. And I'll also put the link in the chat as well. Thank you.
Thank you all. I appreciate your questions.